Hi, my name is Mira Grover, and thank you for watching this short video on how to diagnose a substance use disorder. Before we begin, remember that patient-centered care always involves patient education and consent. So please involve your patients. Make sure that you have informed them of your diagnosis so that they are aware even if they disagree. Check your own biases, manage your own countertransference. There's so much stigma when it comes to addiction medicine, and that stigma is inside all of us as well. So make sure that that is not coming out and that you are providing patients with really good care. If you have any patient-specific questions, please contact Addiction Medicine because, of course, these are educational videos. They are not patient-specific advice, and you are responsible for your own practice. I do not have any conflicts of interest to disclose, and I am not paid by any drug companies. Okay, what is an addiction? So there's tons of different ways to define it. There's an ASAM, CSAM definition, and then we also use the DSM-5 to define substance use disorders. Lots of people have an opinion on whether something's an addiction or not. Patients will have an opinion. Their family members will have an opinion. You'll have an opinion. The nurse that's on will have an opinion. It's your job as the primary provider, so whether you're a physician, nurse practitioner, whoever you are, to know the science and to educate your patients about it. So the ASAM definition, addiction is a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite those harmful consequences. Prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. So what this means is that this is a chronic illness. It is relapsing and remitting. It does not go away, but it can be treated and managed very well. So we use the substance use disorders criteria under the DSM-5 to help guide us when to diagnose a substance use disorder specifically. So here are the criteria for that. And we gauge a substance use disorder's severity based on how many of these criteria they fulfill. Of course, those criteria, the last two are not met if the patient is taking prescribed drugs under supervision. So when we have a patient who comes in who has chronic pain, who is opioid dependent, sometimes people say, is this chronic pain or is it addiction? It can be one, the other, or both. Certainly, opioid prescribing for chronic pain can turn into a substance use disorder. Often I've seen physicians use opioid contracts for chronic pain management when they are prescribing opioids. Opioid contracts are fine if we understand what the purpose of them is. So the purpose of opioid contracts is to help us diagnose substance use disorders early. It's for early intervention. It is not to shame the patients. It's not to let them know that it's a moral failing if they start using these opioids incorrectly. And it should not impact your therapeutic relationship with the patient. So if you are using this opioid contract and you're like, you told me that you weren't going to do this, that is not helpful. It's not therapeutic. It does not assist the patient with wanting to access medical care further. So that is not the purpose of an opioid contract. The only thing that an opioid contract should be used for is to help the practitioner identify behaviors that may signal and that a chronic pain or opioid prescribing has turned into an opioid use disorder. Because of course, lots of opioid use disorders begin iatrogenically, so we cause them. So if you suspect an opioid use disorder, the answer is not like, well, you did not follow this contract, so therefore I am cutting off your opioids. We do not cut off prescription opioids. That is a college concern. So the reason we don't cut off opioids is that people then go into withdrawal, which then puts them at high risk of using illicit substances or using unsafely, which puts them at high risk of harms, including up until death from opioid toxicity. So we do not cut off people's opioids. But then what do we do? If we're just like prescribing opioids, the patient's taking them willy-nilly, what do we do? So there are still ways to manage this. My favorite tool is to reduce dispensing frequency. Like, okay, I give you a month's worth and you lost it all on day 2. All right, we're going to go to daily dispensing now. We're going to go to weekly dispensing now, whatever you feel comfortable with. It's a patient I don't know and they show up and they're like, my doctor cut me off, I'm on these opioids. If I don't know them and I don't know their social situation, I don't know the safety of giving them a month's worth of opioids at a time, I will always do daily dispensing, and sometimes I will do daily witnessed dosing at the pharmacy. You can also consider rotating a patient to OAT if you are concerned about an opioid use disorder and they meet criteria for one. Then you can consider rotating them. So something like Suboxone, Methadone, or Arcadian are options. Again, you can't do this without a patient's consent. If the patient is not interested or willing, you cannot cut them off. You cannot rotate them. All you can do is reduce dispensing frequency. Really important though that you're not getting into this like head-butting relationship with patients. This is not that's not therapeutic. That's not going to help them access care. So all of this, I always provide education to the patient as I go when I'm doing things like this. So I will say, you know what, I have diagnosed you actually with an opioid use disorder. This is not a bad thing for you. This is not does not mean you are a bad person. It means that you unfortunately now have this chronic illness where your body and your brain believe that you need opioids to survive. And so they will constantly be trying to trick you into getting more opioids. It has moved beyond the realm of choice. It has moved beyond the realm of um, your own moral ability to say yes or no. There is a part of your brain now that is co-opting that. So, because when of course, when we describe and define an opioid use disorder, it's used despite consequences, it's cravings, it's lack of control, things like that. So we're always going to be educating the patients as we go, and we're going to be their ally. We're going to be making sure that we are showing that we are on the same side, that we are not judging. In any situation like this, if you are not comfortable, please provide a referral to addiction medicine. We are so happy to help out. That's all I have. That's how to diagnose an opioid use disorder and a substance use disorder. And I hope that it has been helpful. Please contact addiction medicine with any patient specific questions. Okay, thank you very much.